Okay, good afternoon, everybody. Thank you for coming. How many people here are at the moment actively researching, and how many here are taught students? Just so I know roughly who I'm looking at. So, sorry, that's bad questionnaire design. Okay, so hands up those who are actively researching right now, PhD students, postdocs, whatever. That's the vast majority of people. Okay, so got a good idea of who I'm speaking to. Okay, so you will all be familiar with the problem of trying to establish which method to use when measuring a variable you're not particularly familiar with. That can be very daunting. And there are some variables that are extremely commonly used in epidemiology that have profound impacts on chronic disease risk, on health generally, and we tend to think sort of superficially that they're quite easy variables to measure. So if I were to say to you, I'm just going to ask you about your levels of physical activity. Okay, so that intuitively sounds like quite an easy thing to do. Well, I'm a PhD student, I sit in front of a computer all day, and I do virtually no exercise, and so that's pretty easy to do. But actually, there are lots and lots of unfamiliar aspects to physical activity, or diet, or smoking, or alcohol, which they sort of come under the well, I'm going to use this term very loosely, cognitive radar. I don't know if that's a psychological term, it's one I just made up. So they're subconscious things that we tend to do, where we're clocking up things that we eat, or our activity levels, but we're just not aware of them on a conscious scale. Now, what does this actually mean for epidemiology? As epidemiologists, we are interested in discerning ideally the causes or the determinants of disease or health, depending on your outcomes of interest. And certainly in my field of work, we're very heavily dependent upon observational study designs. It's very difficult and very expensive to do experimental trials, clinical randomized control trials, and even though they are referred to as the gold standard, there are still lots of inherent weaknesses in that study design, particularly in the field of nutrition, but also in some of the other measurement domains I'll be talking about. So we are very heavily reliant on prospective observational cohort data. Has anyone here heard of EPIC, European Prospective Investigation of Cancer? I know it's not a big cancer place, so perhaps you're not, don't know of it. But I'm sure you're familiar with large cohorts anyway, because I'm where a lot of your data sets come from. So have a look. I'm glad you're my big screen. Here's a very well-written editorial here by Gary Fraser a few years ago. So, although results from epidemiologic studies of diet have taught us a great deal, much of the evidence remains mired in controversy because of the inconsistency of results amongst apparently good studies. So you've got relatively well-designed studies, well-powered, good, well-resourced studies, but they're turning up contradictory results. Now, of course, that might be because populations would differ. One population is never the same as the other. But it might also well be down to methodological differences in the way you collect data. And his conclusion is that this can be explained by a combination of two problems: confounding and measurement. So confounding, I'm assuming everybody is familiar with these concepts. If you're not familiar with them, just kind of look quizzical, and I'll explain them to you. But essentially, these are the elephants in the room, the spiders in the closet for nutritional epidemiologists. Everything, or almost every dietary guideline out there, almost every story you hear in the news about something is good for you, something is bad for you, which happens on an almost daily basis, they will mostly come from observational studies, and they will mostly be susceptible to confounding, particularly residual confounding, which is where you've not measured something properly, or where you've not measured it at all when you're trying to control for an exposure outcome relationship. And then, of course, there's measurement error. So if I am unable to measure your diet or your physical activity levels with any degree of sensitivity, then I'm not going to be able to separate physically inactive people down here and moderately active people here and the highly active people over there. So I can't see the increase or decrease in risk that happens when you have differences in that exposure. I have an insensitive method, and therefore you're all kind of a bit of a mishmash and the same. So it's very difficult when we trade in relative risk rather than absolute risk to be able to get good epidemiological data unless we can distinguish between different levels of exposure. Here's perhaps something from your domain. Study shows Brits underreport alcohol consumption by up to 60%. Now, if you ignore the horrible up to there, which is virtually meaningless, then it is a well-known phenomenon that people do underreport alcohol intake for various reasons, for trying not to give the impression that they are less healthy than they actually are, especially if they're pregnant or if they're underage, or there's some other sort of additive social reason for why they might not want to discuss or be frank about the amounts that they drink, especially at the upper levels. And so if you are using an alcohol intake assessment tool that is either insensitive to differences in alcohol consumption, or if you overinterpret the data that you get from a very crude instrument, then you're unlikely to get very meaningful or true results at the end of it. And recently, at least in human research, human nutrition research, there's been a real, I wouldn't say a U-turn, but there's been a real sea change in people's attitude towards dietary data. Up until now, yes, we knew there were methodological problems, there are various sorts of bias, but it's got to the point now where some people like this chap here called John Ioannidis, who's a very sort of famous and controversial figure in epidemiology. He's actually saying that a lot of the results that we get from observational epidemiology, especially in nutrition, are not sufficiently robust that we can actually make policy decisions about them or nutritional recommendations, because the underlying data are potentially so flawed. Okay. So as always, I've stolen my own thunder there, but this is essentially what happens when you have poor quality instruments. You end up with flawed data because your measurement instrument isn't sufficiently robust. But not only do you end up with poor quality data, you also end up spending a lot more money on your research than you would have done if you had used proper measurement methods, or the best quality measurement methods. So if you have an insensitive instrument, and you know it's insensitive, let's say it's a food frequency questionnaire, or a physical activity questionnaire, or an alcohol intake questionnaire, then in order to cut through the random error that you get from a crude instrument, you have to recruit tens of thousands of people in order to see any underlying signal there, any underlying association. So that means you've got to recruit more people and much more cost. In terms of biased findings, where you've not measured your exposures or your covariates properly, you end up with spurious findings, and that not only is wasteful, as in you've just spent $3 million or pounds on a study that gave you spurious results, but it's also adds to misinformation in literature that can then potentially lead to these sort of cul-de-sacs. So in nutrition, for instance, in the 90s, a huge amount of money was spent on randomized controlled trials to supplement people in their sort of 50s, 60s with antioxidant vitamins. You may, no, none of you remember. Some of you may remember. And a lot of money was spent on it, and the results came back almost completely null. Occasionally there was a slight increase in risk actually for people taking antioxidant supplements, especially if they smoked. But there was certainly no beneficial effect of taking vitamin C, E, A, and a few others, selenium and that sort of thing. But that all came from an underlying body of observational data that showed people with higher intakes of vitamin C or E or selenium were much less likely to have a heart attack 10 years later. And so, this groundswelling of observational data build up, and everyone said, well, if we can just show that this actually is the case with experimental design, then we can cut huge amounts of healthcare costs just with a vitamin pill. So it's very, very tempting to spend lots of money on this. And that's what happened. So a lot of money has been wasted in spurious results. Now, it's not all doom and gloom, obviously. I'm not just here to tell you basically your science is rubbish and so is mine. But I'm just trying to reinforce to you that using a poor quality method is not just something you do when you can't find anything better. You don't. A really common experience that I and other methodologists have when somebody rings up and says, or sends me an email and says, I want to measure diet in this sample of X, Y, and Z people. And I go, oh, that's quite a tricky population group you've got there. You'll probably need to do this really expensive method and a very time-consuming and labour-intensive method. I go, oh, no, we can't do that. So what else have you got? Well, you could use just a simple validated questionnaire, but it's not really going to give you very good data for your sample. Oh, yeah, well, that's the best we can do. We'll just have that then. And as if it's kind of okay to do that. And it is to some extent. You are going to be accounting for diet to some extent, but you're only going to be explaining a very small proportion of the total variation in diet or physical activity or whatever it is. And you're still going to have, let's say, 80% of the variation completely unaccounted for. So whenever you see an epidemiological paper saying we've found this result and we've adjusted for all these things, have a look at the instruments that they use to adjust for those things, and then have a think about to what extent they've actually done it, and to what extent there is potentially really there's contamination from those residual confounding sources. So in order to get access to good quality methods and methodology, you can go to the peer-reviewed literature. We all have to write up our methods after all, and we all read those methods sections with great care, obviously. And so we can glean a method from a peer-reviewed journal paper. Has anyone ever tried to do that here? Just basically say, right, I'm going to read Smith, Jones and Blogg's 2005. They've got a really good method there. It's even a methodological paper where they've gone to some effort to explain it to the reader. Has anyone ever tried to sort of take that method and use it? Perhaps it's not applicable for psychology. I tried to do it. I tried to do it for instance, with an assay to measure folate in blood, and it was a methodological paper, very well written, and so I bought all the kit, and I took some blood samples, and we worked on it with a project student over the summer. 8 weeks later, we are sort of swearing and cursing at this damn thing because it's just not working. There's so much practical experience that isn't in that paper, where somebody has been working on that method for years in order to get it to the point where they can publish a paper on it. And so that information is not going to be in the paper. Fortunately, I did get in touch with the authors and they gave me some help and it would all work out in the end. Happy story. But if you just try and rely on the literature, it's not going to work. It's very unlikely that you're going to be able to do it properly to the same standard as the people who developed the method in the first place. Sometimes, and I imagine this is actually more of a thing in psychology actually than perhaps it is in nutrition, the instruments you want to measure have proprietary status. So, let's say, in my field there's something called the Dutch Eating Behaviour Questionnaire. I don't know if you've heard of it. It's an eating, it's looking at dietary restraint and a few other sorts of eating, like emotional eating and external eating. That is the proprietary property of, I think her name is Tatiana van Strien or something like that. She's Dutch, and you have to go through a company to buy the questionnaires. So ideally, you're supposed to, buy 243 of these questionnaires to use each one on your subjects, and that costs you a lot of money. And also, you're unlikely to really, if you're just using something off the shelf like that, you're probably unlikely to really get enough information to be able to understand what you're doing properly. So, there's a potential cost there, and also you've got to find them. You've got to know they're there in order to be able to to use them. And that can be complicated in itself, just finding where can I get this tool. And of course, interpreting and analysing can require some experience too. So ideally, what you want is someone down the corridor at your university or your faculty who knows someone or is someone that can measure this thing. Well, that's pretty much what happens at the moment. It's a network of knowledge and know-how. Oh, I know someone at Kiel who can do that really well. Here's his email and here's his website. Give him a ring, give him an email, and you get in touch with him. And you can either collaborate or he can just advise. And that's pretty much how a lot of research works on knowledge networks, which is fine. But there's only so many methodologists out there, and especially if you're working on a common exposure like diet or physical activity, everyone wants to measure them, and your time is very, very limited. And a lot of the time when you're giving this advice, you're not going to get any currency for doing it. You're not going to get necessarily papers or money or anything that you're supposed to sort of accumulate during the course of your work. So it's a drain on methodologists' time, and it's not an ideal situation. So ideally what we want to have is a free resource that provides unrestricted access to researchers like yourselves, where you can sit in your office comfortably over a long period of time, learning key methodological points that will allow you, or concepts that will allow you to measure this domain properly. So, with that in mind, this was developed about 5-6 years ago now. DAPA stands for Diet and Physical Activity Assessment. So the DAPA Toolkit, as we call it, was developed some years ago in Cambridge by the Nutrition Research Centre there, and they came up with a relatively simple website. It's very useful. It's very popular, but it provides quite limited methodological information on how to measure diet and physical activity. So here's a typical page from dietary assessment. This is how to use a food. This is basically all there is on food diets, and you can see that it's not a terribly sort of rich kind of web content. It's very useful for people that need the information, but they have to work quite hard to extract it from quite dense text. And here's an example from the physical activity page. This is the concept of pedometry and what are the things you need to know in order to be able to use pedometers properly. But there's not an awful lot of practical advice, and there's not a lot of guidance as to how to access the tools. So in the case of the pedometer, what are the manufacturers? Where can you buy them? What are the differences in cost between them? That's the practical advice that you need when you're designing a research protocol or a research proposal even. This is a very sort of crude decision matrix. So if you were to hover on these eyes here, it would give you some lovely advice as to the usefulness of combined heart rate and movement sensor in these particular circumstances. So it's basically just a summary instrument of how to pick the right method for the right sort of study. But it's certainly looking very dated now. So since DAPA I was released 5 years ago, it's been consistently very popular, attracting more than 5,000 visits per month, and that remains the case even up to now with that rather dated interface. And since actually the website went down last week as we were transferring it over to a new server, and I was besieged by email saying, "What's happened to DAPA? I really need." I couldn't believe it. So yeah, it's actually still very, very popular, and people are still using it. But there's obviously a lot more we could do with this concept. Websites these days need to be a lot more interactive, a lot more content-rich, and I think also the style of the text could be a lot more accessible too. So a couple of years ago, my boss Nita and Soren, who's a physical activity guy in at my unit in Cambridge. They got a PHSRN grant, that's a Population Health Sciences Research Network grant, to develop a measurement toolkit. Essentially to update it, because some of it hasn't really been updated since 2009, so there's a lot of stuff that's been published since then, some recent innovations. But also expand its remit as well, because the guidance that's in DAPA I is quite generic. It's kind of for the average person, these are the concepts and these are the things you can do. But if you're doing a study in children or in adolescents or in older adults or something, then a lot of those assumptions, a lot of those methods aren't necessarily as applicable. So we want to provide a lot more detailed information that will give the users a lot more confidence that they are applying the right methods, the right concepts to their population of interest. In addition to expanding and updating the existing domains, we're also going to be incorporating these 3 new domains. Anthropometry or body composition. It started off as body composition, but I thought, well, if we're going to do body composition, we might as well do the simple measures as well. So, for instance, you would be surprised how badly people measure weight or height. So it's all very well having methods for measuring complicated types of body composition, but if you can't measure height and weight properly, then you're going to be building castles on sand. Right. So basically anthropometry, everything from measuring weight and height up to MRI and MRS, CT, and other types of advanced, sophisticated measurements. And then, of course, this is the part where it's probably most relevant to you: alcohol intake and tobacco use. Extremely commonly measured domains, but also incredibly powerful residual confounders, things, exposures that have very powerful effects on health. And if you don't measure them properly, then my association between folate and heart attack, if you're not measuring smoking properly, is the effect between folate and heart disease is probably going to be a relatively small effect size, odds ratios of less than 2, let's say. Whereas the effect of smoking on heart disease risk is massive. So if I can't account for even a small portion of smoking through not measuring it properly, then that's going to overwhelm my quite modest little association between folate and heart disease. And so it's very plausible that these 2 domains, even though they're much easier to measure than diet and physical activity, their potential for creating spurious outcomes is probably greater because of their sort of potent toxic effect. So this is what I'm going to try and do as I develop the Toolkit website more. I want to focus on delivering more accessible content, so very concise, very much just to the point. I'm not doing an online textbook or comprehensive fundamentals of dietary assessment. That's not really what we want for a web interface. So very concise, very accessible. And we're also going to be developing streamed online video content showing how to perform certain types of measurements. So I think for PhD students, certainly I would have really appreciated that when I started my PhD. When I was doing my PhD, I had to analyze dietary data from pregnant teenagers who had very limited communication skills, and then that would be recorded by the midwives who weren't that great at recording dietary data, and so I had very messy dietary data. I really wanted somebody to give me practical advice on how to code this data. And although there was loads of stuff in the literature about different types of bias and error, there was nothing out there on the internet or in the literature about actually how to do the day-to-day nitty-gritty of coding. And I assume there are other types of of analysis that you do in your work where there's very limited practical advice on how to do these things properly. So whether it's interviewing skills, which is a 24-hour dietary recall here, or whether it's measuring skin folds, body composition, these are things that where the skill of the measurer makes a huge difference to the quality of the data. Anybody can get someone's skin and squeeze it with a with a pair of calipers. But can you do it to a level of precision where you can get to within sort of 3% difference every single time? That's very difficult. It takes practice. And again, interviewing, anyone can do an interview, but unless you can do it properly, then you're going to end up with very big differences in data quality. So with streamed online media, you can watch that video again and again and again, and glean everything you need to in order to be able to carry out the method to a high level of quality, rather than just watch one, do one, teach one, which I think is sometimes the case. We're also going to be incorporating in the website some free online measurement tools. So don't worry, you don't need to be able to read this. Basically, all this shows is an online FAQ. So this is beef burgers, roast meat, lamb, chicken, bacon, ham, etc. These are just food groups. And so there are huge cost efficiencies that you can make by doing remote data collection online, as opposed to having somebody sit with the participant and tick off lists with them. Your geographical reach is unlimited, obviously, and there are virtually no costs associated with the data collection and even processing, if you can have an automated processing of the data with a macro or some kind of analysis program. So rather than the old-fashioned method, which was have a paper paper questionnaire where the participant can make a complete mess of it if they want to, and then give it back to the study coordinator, who then has to then transcribe that into an electronic resource. This method has much lower potential for error and is virtually labour-free from the study team's perspective. So there's a lot of effort at the moment going into designing and developing secure online data collection systems. And we've got currently the EPIC, the study I was talking about before, the EPIC FFQ, the frequency questionnaire, and also the recent physical activity questionnaire, or RFAQ, which again has been developed in our unit. And so these are bog standard diet and physical activity questionnaires that are valid for the general UK population, that anyone can use free of charge. You just so if you are running a study, you just need to sort of sign up to our with the unit to say, I would like to use your questionnaire, and then you send an email to your study participants. It then sends them through to this questionnaire. They fill it in, and the results are emailed to you already processed. So not just the raw data of once a week, twice a week, but actual nutrient intakes as a result of filling in this questionnaire. So huge efficiencies, completely free of charge. It should open up good quality measurement to people on very limited budgets. This is what it looks like at the moment. This is the new homepage. I've kind of designed it on a bit of a theme of a tree of knowledge, basically. You have to come up with a kind of bit of a hook. You can't. Yeah. So these are the fruit that take you through to the measurement domains. This girl with melon, and this is running people. So you can pretty much figure out what domains they are supposed to relate to, and when you hover over them, they will say in text, diet, physical activity. So you click through on these. I'm afraid that was just a screenshot. I do have the actual version. I do have a live version on another on this computer that's up and running, but I'm going to stick within the presentation for the time being. And so that fruit will take you through to your domain landing page, and someone got some samples and need turning over or something. And then you can go through directly to other self-reported methods like questionnaires, objective measures like biomarkers, or some proxy method perhaps, life stages, so if you're particularly interested in pregnant women or something. You can go directly through to the population or the section that you're particularly interested in. Here's the physical activity domain, so you can see it's working along a nice familiar theme. So hopefully nice and bright and colourful and having an intuitive interface that you don't have to think about in order to be able to use and explore. That was one of the criticisms I had of the original DAPA I. So where are we so far? Well, as you can see, I've designed the home pages and the landing pages, and I've designed the sort of navigational structure, the sections of organisation, how I'm going to lay out the content, let's say. There's a lot of technical content that still needs to be written, though. And so at the moment I'm writing, I'm finishing off diet and physical activity, and hopefully I'll be finished on that, let's say by the end of March, especially the life stages stuff, which I haven't started yet. But there's nothing at all that's been written on alcohol and tobacco, and I'm hoping that content will get written over sort of April, May time this year. So what we're looking for essentially are expert contributors, people that have a good working understanding of tobacco and alcohol assessment methodology. You don't have to be a methodologist per se. You don't have to, your research does not have to be methodological. But if you have really gone to town on a method and researched it, as all good PhD students do, or all good other researchers do, then you will understand its strengths, its limitations, its how to interpret the data properly, what practical things you need in order to be able to do them properly. And so that's essentially what we're looking for. It's people that are able to provide the right sort of guidance to the Toolkit user. So imagine yourself wanting to use wanting to measure a domain you're not familiar with. So let's say you're an alcohol person, you want to measure tobacco, or vice versa. What sort of information would you want to see on that website? You wouldn't want to see a lot of content, but you would want to see really concise, helpful content that would take you somewhere, take you to somewhere constructive and useful. And that's pretty much what we're trying to do. We're trying to convey people in the right direction, so that they leave the site and go on to a resource where they are likely to be able to access good quality measurement methods. And they're not just going to end up using what everyone else has measured before because that's just the way it's done, or which is often the way it happens. Okay, so we're developing a search engine that will find questionnaires that fit the population or the research questions you're interested in. So if you want to measure iron intake in infants in Scotland, then you're unlikely to find a questionnaire that's that specific. But you should be able to find questionnaires that are sufficiently valid that you'll be able to use them. The video content we'll be making over the summer, and then we'll be trying to incorporate as many tools and resources into the site as possible at that time. Okay. So, what can you do to help? As I say, we're looking for methodologically aware people to contribute or to review. If you don't feel sufficiently confident to be able to be involved in writing, or you're not sufficiently experienced, then just as a non-expert reviewer, it would be really good to get feedback on how you found the other domains that you have no interest or no awareness of previously. To be able to tell me or tell us how accessible you found them, whether there are any bottlenecks, whether there are any areas where you felt it could be improved. That would be really, really valuable information whilst we roll out our alpha and beta versions before we release the full version later on in the year, which will probably be around. Well, beta version we're aiming for the 1st of September, so the actual release of the full switchover will be probably around November time. Okay, so, and lastly, these are all people that are involved. Yes, thank you very much for your attention, and questions.